as I was putting this talk together, I was kind of wearing my clinician hat, but also thinking about my scientist hat at the same time and trying to really go across the domains and see if we could, because I know there's a lot of different interests in this group and a lot of fantastic work being done with the Transcendent study. And so I'm hoping that everyone will find a little bit of the vision system they find interesting in this talk, because I learned a lot putting it together. So I have funding from a few different agencies, including the National Institutes of Health, and from Sports Canada, from the Canadian Blind Sports Association, but no conflict of interest with the content presented in this talk. So if we think about vision and concussion and vision, my slides are just, apologies, there we go. So up to about 90% of vision patients with concussion, regardless of age, injury mechanism, or injury severity, will experience vision symptoms at some point after their injury, often acutely, but those can also become persistent and prolonged. And I know Dr. Schneider gave a presentation on the vestibular system not long ago, and the vision system and the vestibular system are quite closely interlinked and intermingled. But I'm going to speaking really to the visual deficit, so either stuff right at the eye and the optical center where information comes in, or visual processing within the brain. And this is just a nice study that was done by Tina Master's group in 2016, and it just starts to give you an idea of what might be going on. So this was a cross-sectional study of 100 adolescents, so ages 11 to 17, who had a history of concussion. And they found that a number of those adolescents had issues with either accommodation, convergence, or with their saccadic eye movements, and that almost half of them had more than one vision issue following their head injury. And if we look at vision problems post-concussion more closely, there's actually quite a number of things that go wrong. Some are quite common. And the most common things, and what we'll see a lot of clinically, at least, are ocular motility issues, so eye movement problem issues, such as things like convergence insufficiency, or an inability for the eyes to turn in properly, as well as saccadic dysfunctions or smooth pursuit dysfunctions or other oculomotor control issues. We'll see issues with the accommodation system, and that may impact people's glasses prescriptions as well. We'll see issues with light sensitivity, which can also contribute to computer screen intolerance, vestibular deficits, which have been talked about previously, and motion sensitivity. And these common vision problems that we see a lot clinically also are the ones that really contribute to a lot of the big symptoms we see post-concussion, like headache, concentration issues, difficulties with reading, difficulty with tracking objects, and also contribute to those balance and spatial awareness issues that people experience. But in addition to those common issues that we'll see in a clinic, there are other problems that we see that we perhaps measure more objectively, and we don't always correlate as closely with symptoms, or we have challenges drawing a little bit of a closer line between symptoms and deficits in these. But we'll see changes in pupil function, changes in contrast sensitivity, which is an ability of our visual system to detect shades of gray, right? So high contrast objects are black on white backgrounds, but in shades of gray, it's harder to tell things apart, and our ability to do that can be impacted following concussion. We can see changes in the retinal structure itself, either in the nerve fiber layer thicknesses or optic nerve volume, and even an increased volume in the retinal vasculature. We can see changes in visually evoked potentials, which is a measure of the electrical signal produced by the retina as the visual information is transformed and moves up the nerve pathways to the brain. We can see changes in visual processing, and also changes really across the primary visual pathway in some really interesting work that's just come out looking at MRI studies of the primary visual pathway. And what's really interesting about these vision disorders, not only are they really common, but there's work now starting to show that the presence of either vision or vestibular problems appears to be predictive of prolonged recovery, which we all know is associated with poor health, quality of life related outcomes, quality of life outcomes across all age groups. So this vision piece, if we can has a lot of potential as a biomarker for those who might develop or move on to become people with prolonged recovery, and also has a lot of potentiation for treatment and rehabilitation targets as well. I want to look at some of these more common visual deficits first, and this is actually an image of someone who might have a convergence insufficiency deficit. Our convergence is a mechanism that allows our eyes to essentially turn in and keep our macula, our sweet spot of our vision, on what we're looking at. And if the eyes line up properly when they're turned in, we see single and clear. But if you have an issue with convergence, the eyes don't turn in properly, which means you end up getting this sort of doubling or ghosting of everything you're trying to read. And looking at the screen, you can quickly see how that knocks on to things like headaches, difficulty concentrating and focusing, because I certainly wouldn't want to read my school homework or anything at work that looked like that for very long. And when we think about convergence insufficiency, or how we measure it, it's actually a pretty simple clinic test. We tend to call it the near point of convergence test, or it can be done with prisms as well, called the prism convergence test, where you're essentially bringing an accommodative target, a small target, towards the eye, and you're watching the eyes turn in as you do so, and you're looking for a point where that patient either reports seeing that image, that small target, go double, or that one of their eyes, instead of continuing to turn in, now turns out and breaks out of that fusion point. That is your break point, and we normally expect that to be within 10 centimeters of the brow or the eye position. And then your recovery point is then you would pull that target back away from the nose, and that's where the eyes would refuse, or the person would report seeing single. And typically we expect that to be within 2 centimeters of your break point. If you need a rule of thumb, we often think of 5-7 as our normal, but it's really something less than 10 and then within 2 centimeters, because facial anatomy does impact that a little bit. And research has shown across platforms that convergence deficits can be present following concussion, and they're also associated with accommodative dysfunction, pseudomyopia, and vestibular dysfunction. And I popped into the chat quickly. Those values are normal for adults and kids, Sharon, so that less than 10, and then that 2 centimeter recovery point is for adults and kids. And we see a reduction in these across adults and kids as well. When we think about those eye movement problems, there's kind of 3 groups we'll screen as clinicians anyway, clinically, and that we can measure with eye tracking devices. So the first being fixations. Normally, clinically, when we're looking at a fixation, we think it to be a nice, stable eye movement and allows us to concentrate and see things clearly. But sometimes after concussion, it's a lot more unstable and shaky, and we can almost see a nystagmus present in some instances following concussion. Smooth pursuits are a tracking eye movement that normally allow us to follow objects as they're moving, keeping our eyes on that object. But there's some research certainly saying that there are deficits in smooth pursuits and inaccuracies in speed or size of those smooth pursuit movements that can make obviously things challenging when you're moving or you're driving or you're trying to track a moving object or play sports. And we see similar changes in saccades. So saccades are fast eye movements that are between 2 targets, and normally they're quite quick and they're accurate. But oftentimes following concussion, they can be too large or too small, or out of alignment with the target they're trying to hit. We look at some of the research on this, particularly saccades and smooth pursuits. It's an interesting space because every eye tracker is a little bit different, and we don't have yet a perfect metric for eye movement deficits assessments post-concussion. We think they're there, but we haven't quite got a perfect single biomarker to indicate which is which yet. Saccades, if you're looking at just the ones that are simple and reflexive, so you flash something in your peripheral vision and you look at it, they do demonstrate abnormal latencies and gains and accuracy, but their diagnostic sensitivity is poor. We get better diagnostic sensitivity on more complex type saccade tasks, so self-paced, so continue to look between 2 targets at a certain rate, or anti-saccades, meaning we throw something up in your vision and say, look away from the target, or even double step saccades where you're trying to make a couple sets of eye movements. Those have more diagnostic sensitivity, but the challenge is they're also more challenging for healthy people without concussion, and so it's harder to use those to differentiate concussion from controls. Smooth pursuits look a little bit more promising right now, and these deficits appear to be present both in individuals with acute concussion injury and with persisting post-concussion symptoms. And smooth pursuit deficits have also been found to correlate with higher symptom burdens. So we're seeing an increased lag, meaning the movements are slower, and a decreased accuracy as well. And interestingly, if you're working with smooth pursuit targets and you're able to modify the cognitive task that's going on in the background, so if there's a working memory load or an attention load, it's suggested that that kind of additional load on top of the eye movement behavior has a potential to increase its diagnostic sensitivity. So there's certainly deficits in both paradigms. And that cognitive load certainly makes them more sensitive, and they're spaces we definitely need to continue to look at. We're also seeing deficits in fixational eye movements, but one of the challenges with fixational eye movements is they're actually really hard to measure even with standard eye trackers that record eye movements with video, because the video just isn't sensitive enough, and we don't get fine enough movements. But there's a company coming out in the States called Sealight Technologies that's using scanning laser ophthalmoscopy, which is a technique used to image the retina at sort of a photoreceptor cellular level. And they're using that similar technology, but they're using it now to track eye movements and fixation. And when you're actually looking at something, your eyes are not perfectly 100% steady. There's constant tiny micro movements, so microsaccades and drift, that essentially keeps the eyes moving the whole time you fixate. And the reason those occur is because the retinal cells, the photoreceptors, once they're exposed to a photon, need a recovery time. And so if our eyes never moved, eventually whatever we were looking at would gray out and go blank. But those microsaccades and drift essentially move what we're concentrating on or fixating on around our retina, so we get a constant percept of it. And this was some nice work done in 2021 when they looked actually in at the fixational eye movements and at those microsaccades and the drift measures using this high precision retinal eye tracking device. And they found that the acceleration, velocity, and amplitudes of these microsaccades were very different in the concussed population compared to a control population, showing that even at that microscope, tiny cellular level, fixation control level, that there are definitely eye movement deficits present. And they've come out with a device that can now be put into clinics. They're working on it. They're a startup company based in the US, but it's another interesting metric to look at. Interestingly, they're also seeing that there's fixation eye movement differences in high-level athletes compared to controls, and this has been seen in patients with MS and other spaces as well. As we shift gears from oculomotor control, we're going to move into accommodation deficits or focusing issues. These are often lumped with oculomotor control, but they're a little bit of a different type of a mechanism. And so unlike now seeing double or not being able to accurately move your eyes to different targets, accommodation deficits are the accommodation system essentially lets us see distance clearly and then near clearly. So it's like an autofocus system on a camera, and it adjusts to make sure that distance and near are clear as our vision and focal system where we're looking changes. This is also the system that fails as we get over our 40s and start to get older, and this is the system that we need to replace with reading glasses, right? So if the system isn't working properly for someone, everything you're looking at actually kind of doesn't look double, but looks blurry because you can't just quite get an accurate focus, which again can make things like reading and concentrated visual work quite difficult. We tend to measure this with assessments like near point of accommodation. Accommodation facility is another measure here, but typically we'll do this by pushing an accommodative target, so usually some text, something that you have to hold clear, up towards your eyes, each eye individually or in binoculars with both eyes together. And we're trying to see how close we can bring that target to you clinically before it starts to go blurry and your system can no longer cope with it. And what's interesting with the accommodation system is, so amplitude accommodation is measured in diopters, which is just the inverse of the distance of the target from your eyes. And we know that normal values of this will change with age, right? So someone who's 40 will have much lower expected normal accommodation than someone who's 10, but across age groups, we're still seeing deficits in the accommodation system following concussion. So reduced amplitude accommodation is really, really common. It's also associated strongly with those convergence deficits, reduced stereopsis or depth perception, reduced accommodative facility, and refractive error changes. Accommodative facility is another measure of the accommodation system, but it's more of an endurance measure where we'll use lenses, plus and minus lenses, to flip between the eyes to simulate changing focus repeatedly between distance and near. And that endurance in that system can also be impacted following concussion as well. And if you're measuring this clinically as a clinician, I've just left the formulas there in the corner as to how we calculate what is expected for your age, should you want to sneak those into clinic and use them. What's interesting with accommodation too, and it's an interesting piece that as an optometrist really gets my brain excited, is that accommodation is closely linked with our refractive error glasses prescription. So if we're accommodating a lot, it can actually make our glasses prescription at distance look like it's more minus or more myopic. And when you start looking at refractive error changes post-concussion, even though the concussion injury, most refractive error is based on the length of the eyeball and then the curvature of the cornea and the lens in the eye. So we know a concussion doesn't structurally make the eyeball grow or shrink, but we do see these refractive error differences following concussion, and a lot of those I think have to do with the accommodation system. So there's certainly a group of concussion patients that actually demonstrate a myopic shift after concussion. And if we put cycloplegic drops in the eyes to relax the accommodation system, that myopic shift will disappear. So this myopic shift can be transient and improve with time occasionally, But more often than not, it tends to be calcitrant, and it will disappear when you put the drops in, but when the drops wear off, the myopic shift comes back. So it's almost like that accommodative system has seized up and spasmed or Charlie horsed, and it's created this pseudomyopia, this prescription that your distance vision is blurry because of the accommodation system overengaging. But it's a significant amount. So oftentimes, on average, it's probably 1 to 2 diopters of myopia. If you had 1 to 2 diopters of myopia and it wasn't corrected, you wouldn't be able to hold the driving license. But there have been case reports of it being up to 10 diopters of myopia in these accommodative shifts. It's also associated with impairments of the accommodation system and convergence insufficiency. And interestingly, some work that's been done in the US in military veterans have found that the myopic shifts tend to be more frequent in blast-related traumatic brain injuries compared to those with non-blast-related TBIs. And at least in those with blast-related TBIs, it was associated with the number of TBIs they had, blast-related TBIs they had. So there seems to be this mechanism where we get this hyperactive accommodation system post-concussion that can shift a refractive error. But equally, there seems to be a group of patients that have this reduction in activity in the accommodation system or the inability of the accommodation system to work as well as it used to. And these are the people that will have reduced accommodation often compared to normals. And so this was some early work out of a group at Boston's Children's Hospital, looking at people who are long-sighted, who typically don't wear glasses for long-distance vision, so hyperopes. And they found that of those patients that they were seeing, almost 200 of them who didn't need glasses full time, they all had these accommodative deficiencies post-concussion. So they really struggled to be able to see anything up close, and were actually recommended to use glasses for near work, some for even distance work, and have given eye exercises in addition. And they found that correction of these small refractive errors, ones that typically in a normal person we wouldn't correct because they see distance clearly, could improve accommodative function, reduce concussion symptoms, and shorten concussion recovery times. And this is certainly something I see a lot of times clinically, is this accommodative spasm or this uncorrected refractive error that really impacts patient symptoms. And it's something I look for as an optometrist often when patients are coming into clinic, because it's a piece that I can add to their care that not a lot of other people are able to look for. So it's a really important piece because it certainly underpins how that accommodative system functions. When we think about refractive error, one of the things that always comes back to my mind then alongside that, almost goes hand in hand, but they're different things, is the photosensitivity that comes with concussion. The reason I think about photosensitivity and light sensitivity with refractive error is sometimes uncorrected astigmatism prescriptions can cause light scatter in the eye and can cause glare and light sensitivity. But that is not the only cause of light sensitivity post-concussion. Photosensitivity is really, really common. It can become persistent and is predictive, again, of prolonged recovery when it's present. And alongside that photosensitivity, we often see what's called computer screen intolerance in these patients, which is where their light sensitivity may be to bright lights, fluorescent lights indoors, but it's often worse with screens, especially screens with high refresh rates like computers and phones. And it may be the brightness of the display itself, but it can also then be further exacerbated by scrolling or moving on those displays. So the motion sensitivity and the scrolling of those screens can also aggravate the symptoms. Clinically, it's hard for us still to we don't have a good objective measure of photosensitivity. I've tried to develop some historically in the past for other areas in parasport work, but everyone's so used to just saying, are you light sensitive? And then if the person says yes, we address it, that it's hard to get a good objective measure of it. But that means it's also hard to quantify evidence-based treatments because we don't really have anything other than patient reports. That being said, we can work through these with tints and filters on people's glasses or screens. We can work on avoidance initially if a symptom tolerance is symptoms are aggressive, or progressive exposure therapies to try and increase tolerance. And there's some research coming out as well looking at non-flickering or non-LED screens. So the one shown on the left on the photo is a non-flickering screen compared to a traditional laptop screen. And those also have a potential as a treatment mechanism for computer screen intolerance that's persistent and cannot be modified any other way. This is some nice work, again, by Kristine Master's group, looking now at the relationships between the visual system and the vestibular system. So this was a retrospective review of 132 files, showing that of those, 88 people had either vision or vestibular deficits. And when we look at this kind of work now, as we shift gears now into more functional vision pieces, balance deficits, vestibular reflex deficits that cause symptom provocation, those smooth pursuits, abnormal near point of convergence, and abnormal accommodation were all associated with prolonged recovery. And so there was a number of factors in here that predicted prolonged recovery that we can assess clinically in the visual system. And interestingly, this paper also demonstrated that although the vision and vestibular systems are separate, they're also really closely linked together. And there were subgroups within the vestibular symptomatic group that also had a number of these vision symptoms. And so there is this real close connection between the two systems. And we see that in other spaces as well. So this is some work out of a grad student from a colleague of mine at Wilfrid Laurier. But one of the tests I'm really interested in from a sports performance and a rehabilitation perspective is called dynamic visual acuity. But unlike your traditional, maybe how we think of it in a physio sense, where the head is moving and the target is stationary, this is a dynamic visual acuity where the letters are moving while you're trying to read them. And so it is much more representative of tasks someone might be doing while driving or playing sports. And this was some work done in varsity athletes with a history of sports-related concussion they were recovered though. So they had a history of concussion at least 6 months prior, but were considered clinically recovered, and athletes without a history of concussion. And we assessed their dynamic visual acuity when they were seated and standing, and then they assessed their balance and their response times as well while they were standing. And interestingly, when we had those athletes with history of concussion move from seated to standing, if they were looking at quickly moving horizontal targets, their dynamic visual acuity actually decreased compared to their seated posture. And it's thought that there's some cognitive trade-off, visual motor cognition trade-off, where to do a complex visual task in a more challenging postural position demonstrated now that they couldn't allocate the same number of resources to both tasks. And so the visual acuity decreased. Balance was they maintained their balance and their response times were maintained, but they had reductions in their visual acuity with these moving targets. And this is a really interesting place to explore when you start thinking about return to sport decisions, because it may actually be in visual cognition or dual task, visual motor coordination, dual task paradigms that we can start to tease out those athletes or those people we see that are clinically recovered on symptom scores, but just aren't fully normal yet, right? And it's quite scary to imagine that an athlete, when you put them in a more complex situation, is now either sacrificing their vision to maintain their balance or sacrificing their balance to maintain their vision to compete, because all of a sudden that may be the athlete that's at higher risk of the next injury. And so there's some opportunity, I think, within the visual system to explore dual task paradigms as well, to look at return to sport and return to life and return to play decisions. When we think about that pupillary light reflex, again, there's a lot of literature out there that says it appears to be altered by concussion. The challenge with the pupil light reflex data is that some of the data you get, some of the responses you get, some of the values you get depend on the light you use. And if the lights aren't the same, we can get different results. So we are certainly seeing across the data sets that things like pupil diameter, min and maximum pupil diameter, the latency or the speed with which things constrict, how much they constrict, how fast they constrict or dilate, and how long, if you remove a bright light source, how long it takes them to redilate to their normal habitual state. All of those variables can be impacted and different between people with and without concussion. And they're showing that there may also be gender differences, meaning that there is more pronounced pupil effects in actually females or women, biological sex, anyway, being female, with pupil responses seeming to, only in females with concussion. So we're not seeing that gender difference in individuals without concussion. It seems to be manifesting only in individuals with concussion. But it's interesting if you look in the literature, because you will find, people that say pupils don't dilate as well and dilate slower, and then you can find literature that says it's also faster, when they are smaller instead of larger. And so we're still trying to work that out, I think, in the mechanisms of how these are injured. And it's possible that both are true through different mechanisms, because we don't fully understand the underlying neurological mechanisms of all these visual defects yet. There's kind of two theories right now, or places they're exploring for pupil light reflex changes. So one being the intrinsically photosensitive retinal ganglion cells, which are ganglion cells that contribute not to our vision, but to our circadian rhythm and actual pupil size control. They follow, or part of their pathway to the brain is unmyelinated, so they thought they might be a good target. But at least in the most recent papers that have come out, It doesn't seem that the deficits in pupil changes are being driven by these photoreceptive cells, which is intriguing because they are impacted in other diseases like glaucoma and macular degeneration, but we're not seeing it, at least in the most recent papers, that perhaps that mechanism isn't driving it. Another possible mechanism that we're thinking about or is being explored is potentially the autonomic nervous system, because much of the pupil constriction, dilation, nervous responses, nervous stimulation comes through cranial nerve 3, which is also the cranial nerve that controls most of the ocular motor movements. It controls 4 of 6 of the ocular motor muscles, and it actually also controls our accommodation system. And we know in more severe brain injury or cranial nerve 3 palsies that you'll see a blown pupil with severe head trauma and cranial bleeds, or you'll see in a cranial nerve 3 palsy, you'll see the eye turn out and you'll see a pupil dilation effect and also an accommodation effect. So it's possible that there's a connection between the pupil reflexes and those accommodation deficits. But as you can see, it looks like we're also having 2 types of accommodation deficits, which makes maybe the 2 types of, 2 directions of pupil changes make sense too. We just don't know yet. I alluded to visually evoked potentials a little bit earlier. So they appear depending on the type of pattern you use. So typically with a visually evoked potential, you'll have an individual fully dark adapted, and then you'll show them a pattern that consists of typically light or dark images, gratings, or checkerboards on the screen, and you'll measure the retinal response and how that is recorded up and through the brain. And when you do VEP measures and the research in VEP in a space, you appear to be able to differentiate between individuals with and without concussion, either on the latency of the cellular responses or the amplitudes, attenuation ratios, or summation indices. But again, we're seeing variations in the protocols used and variations in the response. So there's no consistent pattern across different types of VEPs yet. They've demonstrated deficits or the ability to differentiate between groups on both pattern and steady state VEPs. And attentional tasks as well. If you combine attentional tasks with VEPs, they're also showing some differentiation for concussion versus non-concussion individuals as well, using those kind of indices. We just don't have a perfect one yet that works for everybody. Interestingly, there's some early work, it was done probably about 10 years ago now, that where they were using VEP as an outcome measure to look at vision therapy as a rehab intervention and binasal occlusion as a rehab intervention, because some of these VEP outcomes have been associated with convergence insufficiency. So when people who have convergence insufficiency following concussion, they also seem to be able to differentiate those people on VEP metrics. And it looks like, at least in a couple of studies that were done, that potentially vision therapy and possibly binasal occlusion could modify VEP responses and make them more similar to controls. So it's an interesting target, but again, a space where we've got a lot more work to do because we don't have a perfect single solution yet. This was some work done by a student at the University of Waterloo a few years ago. I was quite fortunate to be able to work with him, but he was an optometrist from overseas and came over to do his master's with us. I was really interested in looking at visual perception. So what he was using were what are called global form and global motion tasks primarily. And so the way these tasks work is essentially they're an array of dots. So the global form tasks are an array of dots in a sort of predictable pattern, either sort of this ring in the top image here in A, or this sort of cross pattern in C. And what we do is essentially with these tasks, they gradually increase the number of dots that are in a random position, so randomly out of the pattern. And then we calculate a threshold and try and figure out where you can no longer correctly identify the shape of the pattern because there's too much noise and the dots are no longer coherent in the pattern picture. So that's a global form threshold. And that's typically considered a ventral stream type task. So it's an image type task. But there's also a global motion type task where it's, again, looking at dots moving in a coherent direction, an array of dots in a coherent direction to detect a motion. And then we gradually increase dots in that moving in random directions and see if you can still detect the overall direction. And that's a global motion threshold detection task. And these are long-standing psychophysics tasks, but global motion is typically more considered to be a dorsal stream task, global form a ventral stream task. And then they looked at a motion discrimination task as well based on contrast sensitivity in adults who had vision symptoms, so who presented to a clinic for care for vision, so 11, but had concussion, I think it was within 3 years before. So they were persisting symptoms, but persisting visual symptoms, and then adults without a history of concussion. And they found that the coherence thresholds for both global form and motion were reduced in the concussion group, and suggesting that the concussion is actually impacting both of those sort of visual processing streams within the brain. So both dorsal and ventral cortical processing streams may be impacted by concussion. The TBI group, or the concussion group in the study, also had worse depth perception or reduced convergence, reduced vergence facility, which is again an endurance measure of your ability to turn the eyes in, except we're looking at how you can turn them in and out over time and change the point of focus. Reduced accommodation and accommodation facilities also. And while contrast sensitivity so if they varied the contrast of dots that were moving till you could detect the motion, that wasn't different between concussion and controls, but there was some relationship between symptomatology. So people with more symptoms did worse on that task. In addition, so this is a new paper that's just recently come out, and this is a really interesting one. I had it sent to me by a colleague, and I was really excited to read it. So it was a prospective observational case control study at 11 level and trauma hospital. A group of those with a history of mild TBI and no TBI. And all of these people in the study had normal retinal fundus exams. They had normal exams. They looked at symptoms, those clinical ocular motor measures. They looked at OCT, which is a optical coherence tomography, which is an imaging technique looking at the retina structure at a more cellular level, something we can't see in just a clinical exam. They looked at contrast. They looked at visual evoked potentials, visual fields, and they actually did MRIs on these individuals as well. So it was a single visit. And they found that convergence was reduced in these individuals, so both the break and recovery points. They had reduced contrast sensitivity, and their visual evoked potentials were abnormal as well, so they had an increased binocular summation index. But in a subset of these individuals, they also had noticed there was retinal damage. So retinal nerve fiber layers were not as thick as they should be. There was neurological damage at the retinal level itself. There was also changes in the optic nerve size and the sheath size. And they actually found in some of the individuals differences in brain cortical volumes as well. And what they did is they ended up using a machine learning algorithm to try and identify differences across the entire primary visual pathway, and found if you combined all of these clinical measures along with these other more objective measures of the brain and the retina, you could identify people who had visual deficits even if they didn't have visual symptoms. And so they did they had some really nice figures in here, and I apologize, my MRI knowledge is not super fantastic. But what they did is they grouped their people with TBI into those who had no visual symptoms at all, those who had either vision symptoms or light sensitivity, and those who had visual problems and light sensitivity. And then when they looked at the individual diagnostic value of the individual clinical metrics, they were reasonable for predicting which group they were in, but they were higher when they combined all the clinical metrics. So on the top graph, you can see where your control group kind of fell, and then about 64% of participants with MTBI or concussion had abnormal scores on the clinical metrics. So what we would examine typically in a routine exam. But if you combined those clinical metrics that we typically use with the visually evoked potential and MRI, they were correctly classifying about 78% of participants with abnormal scores, including people who had abnormalities in their visual system but had no vision symptoms. And they suggested that may be in part because there's a lot of, in people with persisting symptoms, that they get used to what's their normal, where they may not have realized that their vision was abnormal in some way. So there may be some adaptation to those symptoms, or they aren't actually expressed as symptoms. Although there are probably people in there that also don't have vision symptoms that they're aware of, right? So in early stages of other eye diseases like glaucoma, we are also don't notice the symptoms of the retinal changes. And by the time we're experiencing symptoms, the disease is often quite advanced. So all of these findings, and I'm hoping I've convinced you a little bit across the platform that there is the visual system is clearly impacted by injury, and that there is certainly an argument for a comprehensive visual assessment in patients with MTBI. And not just the clinical piece, but looking along the visual pathway and visual processing, and looking across the whole visual pathway right from the eye into the brain. As an optometrist, we tend to function right on the front end and more the optical input pieces. So we are not usually involved in acute concussion management at this point in time. We're more involved in the management of patients with persisting symptoms, and we tend to be part of that multidisciplinary care team. But I'd like to and I just want to tell you a little bit what we do because I know not every optometrist does this work, and we're still trying to figure it out ourselves sometimes as a profession. But one of the challenges with concussion, and this is some of the work I'm trying to do in my lab to help remediate, is there is no real standard optometric assessment for concussion patients yet. But based on the research that's been out there and some of what I've shown you, people do need a complete visual exam, including that refraction, checking to see if there's been a prescription shift and ocular health assessment. We need to pay close attention to their binocular visual functions, including accommodation, convergence, divergence, and then their ocular motor control assessment, so their eye movements. And then we need to look at those other visual deficits, things like their photosensitivity, try and help with motion sensitivity, balance, visually guided motion, some of those perceptual pieces as well. And consider that alongside all of their other potentially non-vision issues that they're having with those persisting symptoms. And when this was a grad student of mine who did some work, just surveyed Canadian optometrists in practice. This is a small number, but of those who responded, so it's certainly biased because I think lots of people who don't see concussion in practice chose not to respond. But of those who responded, most of them, almost all of them actually, were doing full eye exams on people who have had concussion as a starting place, which is a really good to see that in private practice this is actually being done. And a large number of them were also already doing that full binocular vision assessment as well. So about 80% of them were also doing that binocular vision assessment. So it looks like this is being done. What specific tests are on all of these and how people are measuring them, obviously we didn't get into that detail, but what is being recommended seems to be at least somewhat reflected in private practice. And typically when patients were seeing these patients for vision exam, these appointments typically lasted between 30 to 60 minutes, which is longer than I would say for most routine eye exams in a healthy individual. So those are often up to 30 minutes long. And so this kind of time constraint really suggests sort of a two-part assessment where you do all the structural pieces first, refractive error, fundus examination, those kind of pieces, and then really looking at the functional stuff in more detail, perhaps in the second visit, because it's a lot to pack it all into one. And that's typically what we'll do clinically at the school, at least. When it comes to refractive management, we can modify prescription, prescribe changes in prescription, and we will also look at tints and filters if there's light sensitivity issues. We may use prism to help align the eyes better. And really from for me, as an optometrist, I'd like to see us get to that point, or think of it as refractive error really is a structural deficit, right? It's based on the length of your eye more than anything else, and then your accommodation system on top of that. And so modifying your refractive error can actually go on and change accommodation and convergence and ocular motor control and all of those functional pieces that we're seeing deficits in. And so really we should be looking at changing refractive errors first, and then reassessing and using vision therapy if needed, or other things to treat those vision disorders down the road. When we think about vision therapy, there's a wide scope of vision therapy. I know Roger's asked me about this before, and folks have asked me about this, and vision therapy is a hard one. We don't have a lot of great evidence. There's a little bit of evidence, certainly. And vision therapy, in some ways, when I think of it, when I talk to patients, when I talk to my students, I think of it kind of like personal training or physiotherapy for the eyes. But when we look at some reviews that have been done, there is certainly some evidence that suggests that 80%, 82% of this, so in this particular study, 82% of the patients that they reviewed had at least one ocular motor disorder following concussion, be it related to binocular alignment of the eyes, accommodation, or eye movement problems. Vision therapy was recommended in about 80% of them. And following vision therapy, their symptoms, their convergence, their positive fusional vergence, which is another measure of the vergence system, and accommodation all improved, both clinically and statistically significantly. So there is some suggestion that it will work. One of the challenges with vision therapy studies is that we don't really understand the natural history of the vision disorders following concussion in the first place. And there's some work being done. So some of the NIH funding that we have is to try and look at that as a preliminary finding, try and understand how these deficits change over time following the injury in the first place. If we struggle with vision therapy sometimes to say it's time. Is it time that they just got better, or is it the therapy? But I think that at least clinically, there is a benefit to vision therapy, but we don't yet really know exactly what the specific dose is, and we may not have a specific dose. It may be really individualized, which is where we sit now. But at least right now, it appears to be most effective for accommodative dysfunctions, convergence issues, and ocular motor dysfunctions. And these are really programs that can be done in office or at home. We're presenting some work at CCN a little bit later this year that's looking at the effectiveness of outcomes for versus at home or in office therapy. And it looks like they're fairly similar at this point in time. And so we're working on rebuilding those visual functions, good monocular function and binocular function, and incorporating that visual awareness at the same time. But we know there's no real set number of treatments or duration of vision therapy. And so, at least when we recommend it clinically, I recommended frequently monitoring progress, much like you would in a physiotherapy setting or an athletic therapy setting, to see if you need additional treatment, additional training. And well, I know it's frustrating when you don't have a set dosage. We also don't really know how long anyone's persisting symptoms are going to last in the first place. And so it's a challenging place to give a specific dose for an insurance company or anyone else. But I think if you're working in smaller doses and reassessing frequently, you can make better patient-centered decisions, at least along the way. Here's the cat. I knew they would come. There are other treatments that are associated with vision therapy, things like binasal occlusion, prisms, and syntonics. But the evidence supporting these treatments is even more limited than what you have for more conventional vision therapy. And so really, these need a lot more research, and these are really not what I would consider first-line vision therapy resources. These are things where conventional stuff isn't working and patients want to try something else. We do have these options for kind of the exceptional cases. And just as a final plug, I know I'm running tight on time. The other space where the visual system is impacted in concussion is actually in individuals who have vision impairment or vision loss. As our population ages, there's actually going to be a lot of people, not just athletes with vision impairment. But when you have individuals with vision impairment, that optometric assessment is really, really important, because for an individual with a macular degeneration, a visual impairment, or an eye disease, it's even harder to differentiate what vision deficits are related to the concussion and what are related to the pre-existing visual condition. So nystagmus might be normal prior to a head injury, right? Blurry vision might be their normal prior to a head injury, or pupil deficits might be their normal prior to a head injury. And so individuals with vision impairment will require more careful assessment and also accommodations during the recovery periods. The Canadian Blind Sports Association has some nice resources for anyone seeing these kind of individuals. And there's also space for work in this where in the para-athlete space, right, particularly in athletes with vision impairment, the concussion incident rate is probably higher in athletes with vision impairment than in other groups, even compared to other parasport athletes. And as I mentioned earlier, those symptoms are more challenging to recognize. So it's a space where working together as a team and really carefully assessing the visual system is also really important. And with that, I'd like to say thank you, both to everyone who's been here today and all of my students and collaborators in the group as well.